about the practical procedure itself and not much of theory. And the disclosure is that these videos have been taken from neonatology department AIMS and created with the help of residents there. And these are for academic purposes only. And the learning objectives would be a few: that why invasive BP monitoring is needed in neonates, and what are the indications and contraindications, what are the common troubleshooting and how we can manage some of the complications that might occur during invasive BP monitoring, and some brief about exchange transfusion, its indication, contraindications, and the procedure itself. So why do we actually need invasive blood pressure monitoring in neonates? So the crux of the thing would be that the autoregulatory blood, we all know that shock in neonates is difficult to define, and there is no single definition of shock that is at present being used. The autoregulatory range, autoregulatory threshold for the neonates is very narrow, and it is even more narrower in the preterm neonates. So there are three thresholds. One is the autoregulatory cerebral blood flow threshold, a functional CBF threshold, and a ischemic threshold. So we do not know what is the exact PP at which these thresholds are reached. This is still speculative. So what we are trying to achieve by measuring blood pressure is we are trying to see if, at which blood pressure should I act so that the cerebral blood flow does not decrease beyond a particular threshold. The matter is compounded by the issue that when we see correlation or specifically agreement between invasive and non-invasive blood pressures, it is fairly poor. There's a fairly poor agreement even at the lower blood pressure thresholds, that is between 20 to 30. Even at the higher levels, say after 40, there is a broad range of agreement. The agreement is very poor. You can see that the spread of the blood pressure values is too broad. So the whole crux is that the NIBP, or the measurement of non-invasive blood pressure by the BP cuffs, can be fallacious. So that is why there is a need for invasive blood pressure monitoring. So these are the four common indications for which we usually use invasive blood pressure. First would be hemodynamic instability, or a child who is on inotropes, or you suspect that this child is in shock and you have to initiate inotropes. And in that case, that is the first and foremost indication for which we use invasive blood pressure monitoring. Second, and a bit less common indication, would be a child who is having acute kidney injury or congenital renal malformation, and he is hypertensive. So again, as I said, that NIBP and invasive BP records do not agree much. So even for the hypertensive records, to be sure, you have to have a invasive blood pressure line in situ. So we generally put in invasive blood pressure lines if there is a child with AKI, congenital renal malformations, and he is also on peritoneal dialysis. It is always preferable to keep him on invasive BP monitoring. Third indications, if your setup is the one which caters to cardiac surgery patients. So any ductal ligation, the CTBS surgeon usually asks for a post-ductal invasive BP. So we usually put in posterior tibial arteries before the operation because it carries two purposes. First is that while ductal ligation, the surgeon would like to know whether they are ligating by mistake, they are not ligating the arch. So that invasive blood pressure gives them some idea about the post-ductal circulation. And second is that post-ductal PDA ligation syndromes are there, for which invasive BP monitoring should be continued even in the post-surgery period. And fourth is that any neonate who is, when we switch to HFO, we, as a rule, we put in an arterial line if a child is on HFO. So there are two major routes by which we can measure invasive BPs in neonates. One is umbilical arterial catheter, which has already been talked about Dr. Usha. And second is peripheral artery, which is radial or posterior tibial. These are the only two arteries which we generally prick. We do not prick brachial artery since it is an end artery. We do not usually use axillary artery, though some cardiac centers do put in catheters in the arterial artery. And femoral route is also should be avoided since it is an end artery. But in dire circumstances, or if a child is going for a cardiac surgery, we do put femoral arterial lines at times. But usually it should be limited to radial or posterior tibial. So equipments, I'm not going to going in much details. Much has already been said about the pre-procedural asepsis and the drapes. But what you would need is a three-way stopcock, two pressure line arterial domes. We'll be talking about them. Hep-saline solution, as Usha ma'am has already spoken, that the arterial, the Heplock infusion the heparin infusion through the umbilical arterial line is usually 0.5 to 1 units per ml. So we usually dilute 2 ml of Epiloc in 18 ml of normal saline. For putting in peripheral arterial cannula, a cold light source is used. I'll be detailing about it in the later slides. It is important that you keep the dressing you put in a transparent occlusive dressing so that you are able to see the insertion site for the peripheral arterial cannula. So the first thing in the peripheral arterial line, even while you are attempting a peripheral arterial line in neonates, is doing a Allen's test. So it should be done in all cases. There have been cases where the child had only a single radial artery and the ulnar artery was not there, and the healthcare professional had pricked the radial artery and it resulted in a thrombus. So for a medical legal purpose and for a general purpose also, every time Allen's test should be done even in neonates. I'll be going in brief through the procedure of putting in a peripheral arterial line since the umbilical arterial line has already been discussed. So mask, cap and gloves, routine asepsis precautions should always be there. You disinfect the cold light at first. Again, 3 swab technique may be used if according to the unit protocol. If you are using chlorhexidine, then you may use chlorhexidine alone also. Similarly, the skin area should also be disinfected. And again, 3 swab technique depending on the local unit protocol or the single chlorhexidine if the unit protocol states that you can use that also. So in this video, we'll try to show you how one artery looks, the arterial, how would an artery look like under cold light. During the procedure, we do use non-pharmacological measures of analgesia like pacifier or dextrose or EBM. But routine sedation or analgesia, pharmacological analgesia is not usually required for this procedure. As Dr. Usha ma'am had already said that adequate contact time needs to be provided, and till the betadine is dried, then only it should be wiped off again. So you put in the cold light under the wrist, and you would have to create some sort of a dark room or put in sheets around the warmer of the child. You can see this dark line here. So if you observe closely, it would be visible as a pulsating dark line. So this is what the radial artery would like. If you can see, it is pulsating here. So similarly, the posterior tibial artery, for posterior tibial artery, you prepare the local part and you put in. You have to extend you have to put the foot into dorsiflexion and put the cold light under the under the ankle and in the posterior tibial artery. If you can observe, this is the posterior tibial artery, and if you observe closely, this is pulsating. So it is a black cord-like structure. You will see it as pulsating. The healthcare professional is not wearing gloves at present because the intent was to show you how it looks like and not the arterial insertion itself. The insertion process is pretty simple. That with one hand you keep the cold light under it, and from the other you take a 26 gauge or 24 gauge cannula, and the angle of insertion would be around. It depends on the gestation of the child. If it is a term child, you may require 20 to 30 degree of angle of insertion. If it's a preterm child, it is pretty parallel to the skin itself, since the artery is pretty superficial. So you can go in at maybe 10 degrees or something like that. The actual insertion process has not been shown in this video since I could not get a child in which peripheral arterial insertion was being done at that time. So this has already been stated by Dr. Usha ma'am that there's a hazardous area. So the low UAC position should always be avoided if you are establishing an umbilical artery catheter, and it should be in a high position between T6 to T9. Second and important thing would be that the fixation of the catheter should be very meticulous, and since there's a tendency to bleed through the umbilical artery or umbilical vein, transparent occlusive dressing should be done, and proper labeling of the catheter should be there. Which catheter is an umbilical arterial catheter, which is a UVC, it should be clearly stated. There have been some instances in which TPN has been infused to UAC if there was improper labeling of the catheters. So practical tip would be that securing arterial line, the skill is not in putting in a cannula. I think the skill would lie in properly fixing it because the fixation part is is a bit difficult, because if you fix it improperly, the cannula would get kinked, and the proper invasive blood pressure records won't be obtained. It is particularly important for peripheral arterial cannulas. Properly labeling the lines is important, and always it is better to use transparent dressings like Tegaderm, so that you can visualize the insertion area. So if you insert a UAC, say, and you see that this child, just after say 10 or 15 minutes of insertion, you see that one of the foot of the child, the finger is sinuous and the sole is also a bit sinuous. So what will you do next? So the most common reason for this has to be looked for in every case when you insert UAC, as well as peripheral arterial cannula, that the area, the fingers and toes distal to the insertion site are not in vasospasm or in some form of cyanosis. So in this case, either you would have to take out the umbilical arterial catheter, or you can try rewarming of the opposite limb, so that there is reflex vasodilatation of the ipsilateral affected limb. In this case, we had to remove the umbilical arterial catheter actually. So I'll come to the actual setup of the transducer apparatus. So what it essentially is, so ultimately what we are trying to do is, there is a saline plus heplock bag, and there is a tubing from the saline or heplock bag which goes towards into the transducer. This transducer is kept at the level of the heart of the neonate, and then there is a tubing which connects this transducer to a three-way stopcock, which in turn is connected to the invasive arterial catheter and to the artery. So what we are doing is that we are providing a this transducer has is there is a diaphragm in this transducer. So we are providing a fluid in form of saline. There is a continuous level of saline or fluid which is maintained in this system, in this tubing. And the blood from the artery, there are pressure waveforms in the blood from the artery. You can see that there is a pressure waveform which is coming from the artery. This pressure waveform is transmitted to the saline, and this saline then in turn strikes the transducer. So there is a dome inside the transducer which actually oscillates when this pressure is transmitted to it. And this diaphragm or the dome converts this mechanical energy into electrical energy. And this electrical energy is then analyzed by the multipara monitor and is converted into what is the arterial blood pressure, depending on how much the dome is moving. So the other thing is that you have to prime all these tubings. By priming, we mean that you have to put in saline, or we cannot keep it with air. So if there is air, there will be no transmission of these pulse waveforms. So you have to prime these tubings with saline. So this is the whole concept of how a transducer would work, and why do we use saline while connecting the invasive blood pressure monitor. So we'll be showing you a video of how transducer zeroing is done. So here the all aseptic precautions are to be taken. Preferably this has to be done under a laminar flow. So we take 2 ml of heplock and we dilute it in around 18 ml of normal saline in a 50 ml syringe. What you can do is you can take double the amount and actually make it 48 ml and take 4 ml also. But it depends on the unit protocol, whether you are changing the hep saline system within 24 hours or 48 hours. So here the staff has taken around 2 ml of hep saline and she'll dilute it in around 18 ml of normal saline. It has to be remembered that all of these surfaces, the saline has also to be cleaned and triple swabbed. So once you obtain this heplock solution, which is now around 0.5 to, it contains around 1 unit per ml of it is 1 unit per ml of heplock solution. You connect it to a PMO line and you flush this PMO line. So you can see the dome here. So the dome is nothing but there is a transducer set it has on one side, it has to be the blue side. This blue side is the side which has to be connected to the PMO line with the saline solution. So once we connect the transducer, we'll connect the second PMO line on the opposite side, which is this side. So so there's a straight line. So there are two PMO lines in this transducer set, the transducer itself and two PMO lines. Now we'll flush the whole system with saline again. So what the staff is doing is she is pulling up on the blue thing that was there. So once you pull it up, it gives passageway to the distal PMO line. And we flush the whole system with Heplock solution and saline. So this is the three-way stopcock, and ideally, the third part, it should be opened up and it should be flushed as well. So this is the part. The peripheral arterial line had already been established for a child on HFO. So now what they had prepared as a unit protocol, we were changing it every 48 hours, and she is now changing the whole arterial setup, and we'll be doing the zeroing as well. So that whole flush setup is being brought to the bedside of the child. Say if you have peripheral arterial line or UAC, you would do the same thing. The three-way is connected to a 26 gauge cannula, and you will ensure that there is no air in between. You will connect the PMO line now. So one side of the transducer set, the PMO line is connected to the arterial cannula. The other side will be connected to the Heplock solution. So this Heplock will now be shifted to a an infusion pump, and the usual transfusion rate is 0.5 to 1 units per ml. So we usually keep it at 0.5 ml per hour. So you should also know that there is a lot of dead space in this PMO line. Once you connect all the circuits, you should fold the unnecessary part and try to decrease the exposed part of the transducer. So this is the third part. This is the actual part where the electrical signal goes to. So this is connected to the multipara. We'll be showing you the multipara. And this gray line is connected to the multipara. This cord comes with the multipara, and usually this is all the connections that there are mainly three connections. One goes into the arterial line, one goes to the Heplock, and the third one goes to the cord which is connected to the multipara monitor. So this is what zeroing. So sorry. Are you able to see the video? Still see the video?
No, your presentation is visible. And the video
Okay, I'm so sorry. I'll just check. So line zeroing, what do we mean by zeroing of the line? So what we do is we expose the, I'll go back to this and I'll just explain what zeroing is. So you basically open this, you close off the patient side of the three-way stopcock and open this transducer to the atmospheric pressure. So once you do that, what you're doing is you are telling the transducer that this is the atmospheric pressure, and this is not what the this is what is usually like, and it is once it calibrates for it, then you close this three-way stopcock towards the atmosphere and push it again towards the patient end. So here the patient end is closed, and now the healthcare staff is zeroing. So when you go on to the multipara, you will see that there is an option of arterial 0. You press it, you press the option, and it will zero it in. The calibration is done within 3 to 4 seconds, and it shows that zeroing is done. So after it is done, you will wrap up the excess part of the PMO line. You will fold it and keep it safe inside one of the sterile gauze pieces. So this is what the waveform would look like after being calibrated, and invasive blood pressure is being shown on the multipara. So I'll straight on go to what common troubleshooting. One of the common troubleshooting is that there are damped waves. So what is damping? Damping means it can be under damped or over damped. So generally, dampened wave, by what we understand by dampened wave is that the waveform that you can see, like a pulse waveform, it is not very clear and it is slurred. So there are common reasons would be that there is air in the circuit, there are kinks in the circuit, there may be blood clots in the catheter, or the tubings are too compliant. So if there is air, you need to remove that air, and you can always use the three-way stopcock and interrupt the patient side of it, and by the three-way you can flush the saline through it. Kinks, there are sometimes if you use 26 gauge cannula, there are kinks in the catheter, or there are microthrombi. If there are too much kinks and the waveform is not coming properly, then you may need to change the catheter as well. The usual damping is over damping in neonates, and under damping is not too common in neonatology. So if there is no waveform visible, even if there is backflow, then maybe the stopcock is turned off or the transducer is disconnected. You need to check the connections of the transducer on the multipara, as well as you need to check the transducer itself. Sometimes the transducer is faulty. You may need to change the transducer, the transducer setup altogether. If the waveform is present but there is no pressure reading, you need to, and the transducer is fine, then you need to level and zero. So leveling would mean that the transducer has to be kept at the level of the heart of the child, which we do by keeping the transducer on the bed itself, and protect it from the warmer by the heat by the gauze pieces. You may need to zero it again. If there is catheter occlusion, the syringe pump through which Heplock is going on might be malfunctioning, and it might need some flushing. We have already seen that if there are dampened waveforms, you have to ensure that there are no air bubbles. If there are instances in which you can see that there is blood in the pressure tubings, and again it suggests that the adequate pressure from the other side is not being provided, that the Heplock solution is not going properly. And if there is a waveform but you are not able to aspirate the blood from the arterial catheter, it might mean that there is some kinking inside the arterial catheter itself, or there are some partially thrombosed artery, and if it persists, you may need to change it if you really need arterial blood gases. But if the pressure waveforms are fine, you may continue it for a while. So the dictum is use invasive blood pressure judiciously. You have to remove the catheter as soon as the indication subsides. There are always risks of any invasive procedure. Daily, you have to see whether the risk outweighs the benefit that the invasive catheter or the procedure is carrying. Frequent monitoring has to be done for finger or toe tip colors, and you have to look for evidence of distal color compromise. And a unit protocol has to be established for changing the PMO lines as well as the hep saline solution. So this is all for the invasive blood pressure. Now moving on to the exchange transfusion. I think most of the MD students are aware of the procedure itself. So common indications would be alloimmune hemolytic disease, polycythemia, and the less common known or the controversial ones are severe sepsis with scleroderma and severe maternal autoimmune diseases like, say, ITP, in which mother had thrombocytopenia and the child has severe thrombocytopenia also, or even myasthenia, in which a neonate has transient myasthenia also. At times, people have used exchange anecdotally for removal of drugs or suspected IM or toxins. So the two common routes are push-pull method. So if you use umbilical vein for double volume exchange transfusion, it is what we call as push-pull, because you are pushing in the blood from the same route as well as pulling out the blood from the same route itself. In case the umbilical vein catheter cannot be established, what we do is we put in an arterial line, peripheral arterial, like we saw earlier, and we take a large bore peripheral vein. So you take out blood from the peripheral artery slowly, and you put in the blood from the large bore peripheral venous line. So it is what we call as isovolumetric method of exchange. So generally it is used after the umbilical cord has fallen off. Generally after 7 to 8 days of life, if you need exchange transfusion, we generally prefer isovolumetric method. So contraindications to UVC insertion has already been stated by Dr. Umaman. So now coming to why in autoimmune hemolytic disease we use double volume exchange and not single volume, or say why not triple volume, only double volume. So the rationale comes from physiological studies which were done long before that. By doing double volume exchange, you are effectively exchanging the 86% of the blood volume of child. If you use only single volume, you actually exchange around 63% of the blood volume. So why not use triple volume? So they say that you are gaining very little with triple volume exchange, and there is no utility of going to a triple volume exchange. You will rather may cause much harm, because you are actually exposing the child to prolonged hemodynamic compromise for that. So that is why we use double volume exchange in hemolytic diseases. So equipments, again, you need all the aseptic precautions: sterile drapes, 3-way stopcocks, blood warmer preferably, and restraints, pulse oximeter set, and IV sets. And you may use them individually, say, or there is a so you can use either individual equipments itself, like 3 ways, or there is a exchange set also. I'll be showing you the image of that. So Vygon provides a exchange transfusion set also, so you can use that also if that is readily available with you. So I'll be discussing only some salient points, since again that UVC insertion has already been explained. And so what should be the position of the child while preparing for the procedure? So I think some of you might have seen this kind of arrangement. So this is what we used to call as this is from my MD times. So we used to have a circumcision table or circumcision. This has been in circulation for a long time. So generally people used to put the child on this and tie them up, and then perform exchange transfusions. There are some better versions of it still available. So this is from Natus. But you actually don't need a circumcision board or something. You can actually properly restrain on the warmer itself, and you should provide non-pharmacological analgesia to the child, and with some proper restraint. Second, and for the other important thing would be regarding the blood bag. Every blood bag that you actually is every blood bag should be double checked, one by the doctor and second by the nursing staff for the blood group, the patient ID, as well as the blood bag number. And it should be kept out of the fridge for a short period of time before the procedure. So I'm not going into the details of how the requisition is sent, because I think majority of you would be knowing that. But you can use this question I've got from some of the private practitioners here, that you can use whole blood. Previously, it was said that whole blood has to be fresh whole blood, that it has to be within 2 days or 3 days. The reason for that was that if it was stored for prolonged periods, and if so, it might cause hyperkalemia if you perform exchange transfusion with the old blood. But you need to actually consult with your blood bank, since the additives and the other things, how the blood is being preserved in that blood bank. So there are instances in which the additive solution 3 or additive solution 1 is being used instead of CPDA. And it really is no longer a contraindication if the blood is preserved for, say, 5 or 6 days, even 8 days. But that call has to be taken after discussing it with the blood bank. Preferable is always to reconstitute negative PRBCs in AB positive plasma. We all know double volume exchange would entail around 160 to 180 ml per kg of blood, in which 2/3 is RBC and around 1/3 is plasma. So the third important thing is that you should always maintain a monitoring chart. Of course, consent has to be taken before every procedure. A monitoring chart has to be filled in. Indications have to be properly brought out, and a vital monitoring should always be done along with the procedure. So this has to be done by a third person who is not involved in the procedure itself. And any kind of hemodynamic compromise or should be looked at, and blood transfusion reaction should also be looked at. So what should be the rate of actual removal of blood? So generally, as a normal rule, it is said that either we do double volume exchanges either with 5 ml syringes or 10 ml syringes. But it has to be done taken into consideration the patient's weight, the patient's physiological status, and hemodynamic compromise status. So if the patient is very sick and hemodynamically compromised, use smaller aliquots. If he is stable, you may use larger aliquots as well. Based on weight, this is some general guideline, but majority of the neonates would require around some 10 ml aliquots. But if you are doing an exchange transfusion of an ELBW infant, you should prefer using smaller aliquots. So this is a small video from the facility-based neonatal care of preterm infant, which is freely available on YouTube as well. Should I show the video, Akash, or if the time permits, or should I skip it?
Yeah, please carry on.
Replacing the infant's blood with donor blood by repeatedly exchanging small aliquots of blood over a short time is called exchange transfusion. As this is an invasive procedure involving a frequent change in hemodynamics of the baby, it should be performed only on a stable baby who is not in shock. Increased jaundice due to ABO or RH incompatibility are the commonest indication for exchange transfusion. The exchange transfusion should be planned only if indicated as per the guidelines after at least 6 hours of effective phototherapy. In some preterm babies who are at sick or show any sign of encephalopathy may need immediate exchange transfusion when the bilirubin level is in the exchange range. The selection of blood group and the RH for the exchange transfusion is very important. The O positive blood or O negative blood should be used in cases of OA or OB incompatibility, that is where mother's blood group is O positive and the baby's blood group is A or B. Only O negative or baby's blood group with RH negative should be used in cases of RH incompatibility, that is when mother's blood group is RH negative. Any blood used for exchange transfusion should be always cross-matched with the mother's blood. To calculate the amount used for the exchange transfusion, one can multiply the weight of the baby in kg into 2 and then again multiply with 80. This gives double the volume of blood the baby has, and then one can add 25 to 30 ml to this volume for the dead space of the tubing. Prior to starting exchange transfusion, the details of the blood to be exchanged should be checked thoroughly. One should check, is it the same blood group? What is the date of the blood? What is the date of issue of the bag? What is the blood bank number? And what is the baby's name? All the vitals of the baby should be recorded on a chart prior to initiation of exchange transfusion, and this chart is called as the exchange transfusion chart. Prior to starting exchange transfusion, one should empty the infant's stomach, place a OG tube, remove the gastric contents and leave it open drainage. Do not feed the baby for 4 hours prior to procedure if possible. The baby should be securely stabilized using infant restraints. One can use the gauze rolls for this purpose. Sedation and pain relief are usually not required. One should always recheck the OG tube, secure the baby, and the monitoring device should be checked prior to start of the procedure. In a baby on maintenance IV fluid, continue the same through a patent peripheral line. This line may also be used for any emergency medications if they are needed during exchange transfusion. The materials which are important during an exchange transfusion include the resuscitation equipment and medications, suctioning equipment, 2 3-way stopcocks with locking connections, 5, 10 or 20 ml syringes, waste receptacle which can be an empty IV bottle or bag, IV connecting tube, syringes, and sampling EDTA vacutainers for pre and post exchange blood tests. One should ensure utmost asepsis and maximum barrier precautions while performing the exchange transfusion on the baby. Hence, you can see that the doctor should wear cap, mask, sterile gown, sterile gloves, and the baby should be adequately draped. Now we will be describing the technique of exchange transfusion by the push-pull technique using 2 3-ways. Connect the 2 3-way stopcocks in serial and ensure that all junctions are tight to produce a closed sterile system, ensuring there is no air in the system. The proximal stopcock, that is the stopcock which is near to the umbilical venous catheter, is attached to the IV extension tubing which drains into a sterile waste container. The distal stopcock, that is a stopcock away from the umbilical venous catheter, is attached to the IV extension tubing which is connected to the blood bag which contains the blood with which the exchange will be done. The first step is to withdraw the blood from the baby. Kindly note the position of the 3 ways for this step. The usual volume of the blood withdrawn in each aliquot is 5 to 10 ml. The sicker, the smaller the baby, the lesser aliquot should be used. The second step is to discard the withdrawn blood into the sterile waste container. Kindly note the position of the 3 ways for this particular step. The third step is to withdraw the blood from the bag. Note the position of the 3-way for this important step. The fourth step is to infuse the blood which is withdrawn from the blood bag into the baby. Note the position of the 3-way for this important step. Hence, the single cycle needs these 4 steps to be done serially, and in this way, one cycle is completed when all the 4 steps are done. Once a cycle is completed, it should be ticked and marked in the exchange transfusion chart. In a similar way, the repeat cycles are done until estimated cycles get completed. During exchange, one should always keep a watch on the vitals of the baby. If there is an undue fluctuation in the vitals or the baby has apnea, the cycle should be withheld immediately till the baby is stable. Be sure that there is adequate volume of donor blood remaining to infuse after the last withdrawal, and intermittently gently agitate the bag so that there is no accumulation of the RBCs beneath the bag. Clear the umbilical line of the bank blood and withdraw amount of infant's blood needed for laboratory testing at the end of the exchange transfusion. After the exchange transfusion, the baby should again be closely monitored for at least 4 hours. There is no need to add routine antibiotics. The calcium should only be added if there was a demonstrated hypocalcemia, and there is no role for using heparin routinely during exchange transfusion. Once the exchange transfusion is done, remove the catheter. Thank you.
So the procedure was elucidated in the previous video. The common complications that we used to see were hypocalcemia, but as stated in the video, it is not so common, and no prophylactic use of calcium or antibiotics should be done. Hypocalcemia used to occur when CPD was used as a preservative, and the blood banks might be using some other preservatives now as well. There are concerns that it might cause some thrombocytopenia or metabolic acidosis, but routinely, if all aseptic precautions are taken into consideration, the procedure is pretty safe. As I said earlier, there is an Vygon exchange transfusion kit which is also available in the market. One may use it if it is ready available. And now coming to the another area where exchange transfusion has been widely used, especially in LMICs, is that in neonatal sepsis and neonates with scleroderma. There are some centers which use it routinely, but again the evidence is lacking. There was a recent meta-analysis published by the St. John's group from Bangalore and Suman Rao ma'am, So what it included around 23 studies, but there were only 3 RCTs. Rest were only cohort studies or control studies or case series. What you need to see is that two things, that the numbers were pretty low. If you see the numbers, the each individual study had pretty small numbers. Individually, all of them were underpowered, even the trials. And majority of the studies were done in the early 1970s or 80s. Only a few studies are available from this decade. So taking all this background into consideration as well, when they analyzed all the data and including only randomized trials or retrospective studies or non-randomized control studies, they did show that in mortality there was some benefit. There was around 28% reduction in mortality, but again, there was low certainty of evidence, high level of bias, and very high heterogeneity. All of the individual studies were underpowered, and majority of these studies were old. And with a very now the population in which we might use this intervention for sepsis will be very different. And so they concluded that there cannot a direct recommendation cannot be made to use routine exchange transfusion in neonatal sepsis, even in neonates with scleroderma, but it may be considered on a case-by-case basis in centers where adequately equipped to manage such neonates with invasive BP monitoring or hemodynamic compromise. But they did mention that it requires a rigorously conducted trial to actually say whether exchange transfusion may benefit in mortality in neonatal sepsis. So that's it from me. Thank you.